in 15 minutes. I check the hardening of the MTA, and then I can go on with my direct restoration. So I do the total latching procedure, enamel first for 15 seconds, then tin, then for 15 seconds, and then I go on with the application of primer and the bonding, and I do the direct restoration and compression. This is the result. 1 year later, the restoration is still there, and the tooth is like this. There was a pipe stone before, there is a pipe stone now. I have no periapical symptoms. The tooth is vital. So, we bought time for our patient. We postponed any possible endodontic treatment, because this is how it has to be done. So when do I do endodontic treatment? When I have irreversible pulp pathology, there is no other way to treat the tooth. Or when the pulp is necrotic, we have no option. Or, and this is an elective treatment, when we know that our procedure are going to compromise the vitality of the pulp. For example, I have to place a crown on a tooth, so I have to do my preparation, but I see on the X-ray that the pulp chamber is so close to the finishing of my preparation that, to be sure, I decide to do the endodontic treatment. Or when there are traumatized teeth that are avulsed or dislocated. Or again, with internal resorptions or external resorption who go interested in the pulp. Or when I have cracks or fractures that the pulp is involved. Or when the patient has a crazy hypersensitivity and we are not able to manage it any other way. We do the endodontic treatment. But all over the world, all of the scientific society agree that there is no successful endodontic treatment if we don't use the rubber dam, because isolation is mandatory in order to succeed. And what the vast majority of the dentists that don't use the rubber dam say is that it takes a lot of time to put the rubber dam on. Well, it takes from 20 to 60 seconds. So that's not the excuse. And one might complain about the fact that patients don't like the rubber dam. It's 1.5% the number of patients not accepting the rubber dam. All of the others, if informed correctly, accept the rubber dam. And most of them, at the end of the procedure, tell you, oh, doctor, this is so comfortable. So we only have benefits in using the rubber dam, because we see better what we are doing. We have an improved access to the area, because we remove all what can interfere with our concentration. We protect and retract the soft tissues. If it ever happened to you to cut the cheek or the lips or the tongue of your patient with a burr or a disc, with rubber dam this doesn't happen. And also, you protect the patient from ingesting what you are using. Burrs, pus, irrigants, blood, whatever. It stays outside of the mouth of the patient. And you have one hand free, because you're not holding the cheek with your hand. And also, you have a better outcome. You reduce the time of the therapy and you have a legal protection. And post-COVID, the only treatments that we were accepting to do were those in which we could use the rubber dam, because it was protecting us. And this is what happened. That patient ingested a matrix, this patient ingested a file. This can be a huge problem for you if it happens in your practice. And if one has the excuse that I don't have the rubber dam, because it's expensive. My question is, do you have gloves in your practice? Here is a homemade video with an extremely sophisticated tool, a pair of scissors, that show you how to make rubber dam out of a glove. One single glove. You can do it yourself, or if you have an assistant,
học cái này
you can do it with an assistant.
Không phải mua.
The result is the same. You cut the thumb first, then you cut the other finger. And then, if the assistant helps you, you're even quicker. And then you open up the side of the glove. You open it up and you have a latex sheet. And I cut that part because it doesn't look nice. Then you take your punch and you do the holes inside of the latex. You place your clamp, you open it with a forceps, and you're ready to go. The cheapest rubber dam, so no excuse for not using it. What are the timings of endodontic treatment? So diagnosis, access cavity, mechanical shaping, that takes
dài ta to cắt ra từng miếng một là được.
a short time. I take a lot of time to do my access, short time for shaping, then cleaning, long time, and then restoration. In this case, I saw this patient that she has pain on the upper right part of the face. You see she has a bridge and there is a large decay over there. But the tooth responsible for her pain was the second premolar, because she had irreversible pulpitis. That tooth was already half necrotic. So what do? I start from the chief complaint. I do the endodontic treatment on the premolar. So you see I have removed the bridge and I have placed the rubber dam with a clamp that you usually have to use in an incisor, but the size of the premolar is small, so this is the best fitting clamp. I remove all the decay first, and then with ultrasonic tips I go designing my access cavity. I want to remove completely the floor of the pulp chamber. I irrigate because I see nothing and I cannot shape when there is an extensive bleeding. And then I do a completely mechanical preparation of the root canal. I use this file, which is called PX, and it is a file designed for making the glide path. I use it in the coronal 2/3 of the canal, then I switch to a 20/0.4 in taper file. I use it only in the coronal and middle third. The same with a 25/06, only the coronal and the middle third. What did I do? I did coronal pre-flaring. I remove all of the obstacles between me and the apex. And then I can take my manual, number 10, K5, and check the working length. So I can bring to the working length the 3 files you have seen before. So I bring my glide path file, I bring the 20/04 file, and I bring the 25/06 file. What am I searching for? I'm searching for my visual gauging. That means that the tip of my file has to be covered in white dentine. This is the sign that I have shaped the apex. If I hadn't this kind of feeling, I would pick a larger diameter file and I would pass it. I am finished with my shaping in a few minutes. Then I spend most of the time irrigating and activating the irrigant, because we have to remember that we shape to clean, to allow a larger volume of irrigant to flow towards the apical third of the tooth, which is the part of the tooth in which we have the highest concentration of anatomic variation of bacteria, so we need to clean over there. And then I check the fit of my gutta-percha point. I have to feel some resistance while I try to take it out of the root canal. This is called the tag back. And then again, I dry the canal, I put my bioceramic sealer on the gutta-percha point, and I fit it into the tooth. At this point, I'm finished with my endodontic therapy. I only have to cut the part of the gutta-percha point that is coming out from the orifice. And I do it with a heat plugger. And then I plug the gutta-percha. And if I did the single cone technique, I will be done here. I want to do a warm vertical compaction technique. So what do? I set my plugger 4 millimeters short from the working length, and I go heating the gutta-percha down there, and I pack it. I heat and I pack. This allows me having a more dense obturation and increases the chance of filling lateral canals, for example. This is how clean your cavity has to be if you want to proceed with the therapy, and with bioceramics it's very easy to achieve this goal. And then what do? I restore the tooth and I take care of the other in a following appointment. And to put the rubber down there, I have to do a small preendo build-up. And this is the treatment of the second molar. This is a similar situation, but with a necrotic tooth. You see the lesion on the first premolar. I do the same. I remove the bridge, I do the endodontic treatment, and since the patient has no money and she wants me to save her existing bridge, I do it. I place a fiber bone and I do a post-endodontic restoration and I use her bridge. And she, 8 years later, is still like this. So we can do also affordable endodontics. Sometimes it's not so easy to determine which is complete. It was a Saturday at midday, and this patient came as an emergency appointment in my practice. She lives in Verona, which is 2 hours away from where I work. And she arrived crying because she hasn't slept for 2 days, because she was in pain. And I asked her, what is the reason of your pain? What exacerbates your pain? And she was like, I'm in pain with cold, with hot, and when I bite. So the whole pool of symptoms. And so she tells me that she has received a pulpotomy on the second molar some days before, but she still has pain, maybe even more than before. So help me. What is the tooth responsible for her pain with cold? Raise your hands. Second molar, first molar, or second premolar? Who says that it's the second molar, the responsible for the pain with cold? Nobody. Who says it's the first molar? Nobody. So we all agree that is the second premolar, the responsible for her pain with cold. Yes, because it has an irreversible pulpitis, a large decay close to the pulp. And the responsible for the pain with heart is obviously the second molar, in which they attempted to do a pulpotomy but they left the pulp inside. And so the pulp pathology went on, and so now she feels pain with hot, and she's relieved by the cold. And the precaution is obviously the major root of the first molar, because there is an endodontic lesion with a poor endodontic treatment. Now there's a problem. 3 teeth with problems. What do I do first? I call my husband, I tell him, don't wait for me. And I do the endo on the second molar. I remove all of the existing filling from the first molar, and I do a pulpotomy on the second premolar. And if you watch carefully the x-ray, you know why I didn't try to do the endodontic treatment on the second premolar in the same visit. Because it has 3 separate roots with 3 root canals, so it's difficult. I want my mind to be fresh when I have to do such a case. And so, in the second appointment, I did finish the retreatment on the first molar, and I did the treatment on the second premolar. So I finished my endo. Like, you can have the restoration if your dentist in Verona, because I'm very far from you. I don't want you to drive for 2 hours. I have sodium endodontic problem. And this is where I did a mistake. Because look at this restoration. There is no seal here. And so there will be coronal leakage. Despite this, the endodontic succeeded because the lesion disappeared and she is symptom-free. But there's a respiratory failure, so I don't know how my endo success will last. Because bacteria can come inside the root canal and reinfect everything again. And there's another problem. Big decay here, big decay here. So I tell her, get a restoration. Yeah. And so she comes up again. And she has had a pulpotomy in Verona. And they did it wrong because they didn't understand. And also these two have 3 separate roots. And you can see it clearly when you prepare the x-ray. So the shape of the axis was that one. The shape of the correct axis is this one, because we have 2 buccal roots. And so, 3 root canals. The sequence, the same as explained before. So I use a small 15 into 3% in taper 5 for the glide path. 2004, 2506. I did the coronal flaring, and then I took all the files to the working lab. This is working lab termination, and this is post-operative. And this time I also did the restoration, just to be sure. And the curiosity, the rarer the anatomic aberration, the more